Hello, everyone. Thank you for joining us today for our webinar entitled MACRA, MIPS, and APMs, Exploring the New Quality Payment Program. Today's presenter is Bruce Mackey, MCEDA Regulatory and Incentive Program Analyst. My name is Liz Jones, and I am today's moderator. Before we begin, I have a few housekeeping items to touch on. We will be keeping the phone lines on mute during today's presentation. If you have a question for Bruce, please type it into the questions box in your GoToWebinar interface. We'll take time at the end of the presentation to answer any questions you have. If for some reason we are unable to get to all of the questions, we will email you directly with an answer following the broadcast. We will also be posting a recording of today's presentation on our website, mceda.org. A copy of today's slides are available there now by going to www.mceda.org. Hover on the Resources tab, then select Webinars. Also, the presentation slides are currently available in the Handout section of your GoToWebinar interface. The information you will hear in this broadcast is current as of today and is only intended to be a general summary. Since Medicare and Medicaid policies change frequently, the best way to stay up to date on current requirements is to review the actual written law or regulations. We encourage participants to review the specific statutes, regulations, and other interpretive materials for a full and accurate statement of their contents. We have a lot of information to cover today. We will start out by giving you a brief overview of MCEDA and our various service offerings. Following that, Bruce will take over and provide a high-level overview of MACRA. From there, he will spend the majority of his time introducing you to the Quality Payment Program and some of the key facts contained within it. Following the presentation, Bruce will take time to answer any questions posed by the attendees. Housed within Alterum Institute, we are MCEDA, the Michigan Center for Effective IT Adoption. Originally born out of ARA, and more specifically the HITECH Act, MCEDA is Michigan's regional extension center, tasked by the federal and state governments with accelerating the selection, adoption, and meaningful use of health information technology to improve the quality and efficiency of healthcare in our state. To date, we have assisted nearly 6,000 providers across Michigan, impacting 1.6 million patients annually. Ranked as the 5th largest REC out of a national network of 62, we are also funded by the state of Michigan to assist any provider participating in the Michigan Medicaid EHR Incentive Program. MCEDA's health IT services include the following. Number 1, meaningful use support at any stage and year. Providers participating in the Medicaid EHR Incentive Program also benefit greatly by qualifying for state-subsidized services that brings our highly rated technical assistance to you for only $200 per provider, a savings of 96% compared to commercial service rates. Number 2, security risk assessment, which is an embedded service within our meaningful use support. But if providers have meaningful use handled and only need assistance with the SRA, we offer it separately as a standalone service. Number 3, attestation and audit preparation. If you are getting ready to attest to meaningful use and just need some peace of mind that you've crossed all the T's and dotted all the I's, or if you're one of the many folks who have been selected for a meaningful use audit and need assistance responding, we are here to help. Number 4, targeted process optimization, or TPO, takes a stripped-down version of lean principles and applies them to any clinical or operational practice improvement initiative. No matter what you need help with improving in your practice or clinic, we have experts on hand who can assist you. Number 5, the Great Lakes Practice Transformation Network offers no-cost technical assistance to eligible providers in support of quality improvement initiatives, PQRS support, and preparing for the upcoming advanced payment model changes under MACRA MIPS. And number 6, our chronic care management program enables physicians to take advantage of the recently updated Medicare billing requirements for CCM services. We provide you with a dedicated care manager who works within your practice, helping fulfill CMS criteria to maximize your reimbursement potential. Contact us to learn more. With that, I will turn things over to Bruce.
Thank you, Liz, and thank you everyone for joining us today to talk about MACRA, the new program that's coming at us. I do want to pause here and just mention Liz already talked about the slides being available both on our website as well as in the handout section of the GoToWebinar interface. If you look in the handout section of the GoToWebinar interface, you'll see two different handouts there. I loaded the full slide version, and I also loaded the 3-slide with notes version, so you can pick and choose whichever one you'd like, or both. So today we are here talking about MACRA, and I have a tremendous amount of information that I'm going to pack into the next hour and 15 minutes or so. With any luck, I will have some time at the end for some questions. Some of the slides I'm going to breeze past just in the interest of time. I just wanted to transfer the information to you, but won't necessarily spend a lot of time discussing each and every one of these slides because I've got about 73 of them to get through. So first off, I will call out the glossary. I've been asked several times to stop talking in the alphabet soup that healthcare forces us to communicate in. So here is the list of acronyms I will be touching on throughout the presentation today. So what is MACRA? So it is the Medicare Access and CHIP Reauthorization Act of 2015. It's otherwise known as the Doc Fix Bill. It is called this because it was bipartisan legislation that really can happen in today's Congress. It replaced the SGR, the sustainable growth rate that was plaguing us for many, many years. Finally, it is gone and is replaced with this much more predictable program called MACRA. It's going to increase the number of physicians that are participating in something called alternative payment models, or APMs, and I will talk about that quite a bit throughout this presentation. And with those in high quality, efficient practices benefiting financially, and quite significantly so. As the name would suggest, it extends the funding for the CHIP program for an additional 2 years. And the main thing it brings to us, and what we'll be discussing today, is the quality payment program. It is part of this broader push towards paying for value and quality. It's no longer just a sheer numbers game where the more claims you submit, the more money you make. Now quality is a big, big part of it. There are some embedded goals attached to this program. Goal 1 being 30% of Medicare payments tied to quality or value, alternative payment models categories 3 and 4 by the end of 2016, and 50% by the end of 2018. They met that 2016 goal, I think, in March or so of last year, and are well on their way to hitting all of these goals. Goal 2 was 85% of Medicare fee-for-service payments tied to quality or value categories 2 through 4 by the end of 2016, and 90% by the end of 2018. I'll talk about what those different categories are if you're unfamiliar with those on the next slide as well. And then in the lower right-hand corner, you see that there's this overarching goal to invite the private sector payers to match or exceed the HHS goals. That is in reference to private payers, which we will see over time. We'll see the private sector come in with similar programs. I think they're all going to sit back and see how CMS or how Medicare does in this program for a little bit before they venture into those deep waters. But eventually, we'll see the private sector come in with similar programs. Here is a diagram that shows you the different categories that I made reference to on the previous slide. You can see down at the bottom of the staircase here, category 1 was pure fee-for-service payments. That's really where we've been for years and years. As you get up this staircase, we push towards linking to quality. Then we get into categories 3 and 4, which is really the overarching goal of the program, is getting folks into these alternative payment models and starting to pay for population-based and really downside risk, or embedding risk into the model is the overarching goal here. The long-term aim of MACRA then is to shrink that fee-for-service bubble, that one, as you can see in the current state diagram here. It is very large and with very little happening in kind of the middle of the staircase there. And then the overarching goal is to shrink that fee-for-service bubble as small as we can get it and get everyone up that staircase into those models that are paying more for quality and kind of building some performance metrics in, starting to have some downside risk if you're not meeting quality objectives. There are some strategic goals for the QPP, improving beneficiary outcomes, enhancing the clinician experience, maximizing participation, increasing the adoption of advanced APMs, which I'll talk about what those are, improving data and information sharing, and ensuring the operational excellence in program implementation. Those all sound really great, don't they? I call your attention to the website there in the quick tip box at the bottom, that qpp.cms.gov. That is your one-stop shop for everything related to the QPP. There is a wealth of information. I think CMS has done a great job on setting up this website. I don't always say that about CMS websites, but this one actually is pretty darn good. There's a wealth of information there, and really anything that I'm touching on here, any of the spreadsheets or quality metrics, all of that stuff you can pull from the QPP website. So looking at kind of a conceptual diagram of MACRA, this is as simple as I can make it for you to kind of give you that framework for what we're talking about here. At the very top we have MACRA, that is the overarching legislation. There is a whole lot of stuff in MACRA. We are talking about a very small portion of it. There are many other regulatory changes, but the main thing we're talking about here is the QPP, or the Quality Payment Program. Within the QPP then, there are two tracks that you can be on, one of which is MIPS, or the Merit-Based Incentive Payment System, and the other one are something I've already referred to as APMs, or Alternative Payment Models. And then within APMs, there's really three, but we're going to talk about two different APMs. We have the non-advanced APMs, otherwise referred to as MIPS APMs, and then advanced APMs. And it's kind of the gold standard. That ultimate goal here of the program is to get as many folks into those advanced APMs as possible. Initially, the majority of folks are going to be participating in track one, the MIPS track. And over time, we think we'll see the MIPS participants shrink and more folks in the other track, the APMs track. We've got some projections there at the bottom for how many folks we think in this first calendar year will be in each of the two tracks. So we'll talk now about path one, the MIPS track. So what is MIPS? It is the Merit-Based Incentive Payment System. It combines multiple Medicare Part B programs that you have most likely already been working in for a number of years. It combines them into a single program. So it takes the Medicare EHR Incentive Program. I'll pause here and point out that that is very specifically just the Medicare program. The Medicare Meaningful Use Program expired. 2016 was the final performance year. The Medicaid Meaningful Use Program is alive and well. It is not going anywhere, at least not that we're aware of today. And so that is transitioning into stage 3 and will continue through 2021. So for now, if you are a Medicaid Meaningful Use Program participant, but you are also a Medicare provider, for now you are going to be participating in both programs. So you'll be attesting 2 different times. So you'll still have to do your Medicaid work in Meaningful Use, but then you will also be separately participating in MIPS. Participating in the Medicaid Meaningful Use Program does not automatically give you credit in the MIPS program, like we've seen previously, previous iterations of these programs. So it takes the Medicare EHR Incentive Program, it takes the PQRS program, it takes the Value-Based Payment Modifier, which really wasn't affecting a whole lot of folks yet. It adds a 4th category called Clinical Practice Improvement, and combines them into this new program called MIPS. I do also want to point out that we are getting away from the term meaningful use in this program. It is not referred to as meaningful use, even though there is a component that will look very meaningful usey to you. It is really called Advancing Care Information now in this new program. So it's ACI, or Advancing Care Information, under MIPS, and it is still considered meaningful use under the Medicaid program. So who's eligible for this program? In the first 2 years, for this year and next year, that list is finalized. There are 5 different provider types that we have listed here. The MDs, that includes DOs. We have PAs, NPs, so those mid-level providers can participate. And then we have clinical nurse specialists and certified registered nurse anesthetists. Those 5 provider types are eligible for the program. We do expect to see this list expand, although it has not been finalized as of year 3 on. The Secretary will most likely expand that group to include several other mid-level providers, some of which are listed there on the screen. I do also want to point out that we do have another term change. We are getting away from the term eligible professional, or EP, as we have been using in both PQRS and in the Meaningful Use program. It's now being replaced with the term eligible clinician, or EC. So for the remainder of this slide deck, you will see me refer to them as ECs. So who's exempt from MIPS? Who does not have to participate in it? So we have first-year Medicare Part B participants. So if you just became a Medicare provider, in your first calendar year, you do not have to participate in MIPS, but in your second calendar year, you do. So you don't get an entire year off necessarily. It all depends on when you submit that first Medicare Part B claim. That's when that's the calendar year, whatever calendar year that falls in, you're exempt from participation in that year, but the following year you do have to participate. The low volume threshold is where we see a lot of folks kind of falling off from this program, or are not having to participate. That low volume threshold is Medicare billing charges, so that's the allowable charges, of less than or equal to $30,000, or provides care for 100 or fewer Medicare patients in 1 year. So to be a participant in MIPS, both of those conditions must be true. You have to, in a calendar year, you have to have more than $30,000 in Medicare Part B charges, and provide care to over 100 Medicare patients. If either one of those conditions is not true for you, then you are exempt from participating in MIPS. The dates that CMS is using to figure this is September 1st of 2015 to August 31st of 2016. So you should be able to go into your practice management system and run some reports to see where your providers fall now, or see where you fall. CMS is supposedly, I understand, going to be sending out some letters to folks sometime this month, letting them know if they are if they need to participate or not. We'll see what those letters look like. I also have a concern. I've also heard that only one group is going to receive letters, meaning either the folks that do need to participate or those that don't, but not both groups. Hopefully both groups will get a letter to indicate, but we will have to wait and see. And the other group that does not apply to is certain participants in advanced alternative payment models. And I will talk a great deal about what that means, what it means to be a certain participant, and what it means to be in an advanced alternative payment model. MIPS also does not apply to hospitals or facilities, although critical access hospitals it does. There are a couple of different ways that you can participate in the program. You can participate as an individual. That is a provider, an NPI and TIN combination, a tax identification number combination. So you can just use that one individual's information to get your score, and I'll talk about that. Or you can combine things and go in as a group. So as a group, it is 2 or more clinicians who have reassigned their billing rights to a single tax identification number. And if clinicians participate as a group, you're assessed as a group across all 4 of the performance categories. I've already touched on what those are, and I'll go through all of them in great detail. There's a third way then also, as you can participate as an APM entity, and I'll talk about that as we get a little deeper into this too. So a couple of different ways to participate as a group. So as part of that, that low volume threshold that I talked about, the $30,000 and 100 patients, that does not change if you are participating as a group. Those conditions remain the same, but you're going to meet it by combining the charges and the patient counts from all the group members. So that could be a way to, if individually each provider does not meet that low volume threshold, that might be a way to get everybody into the game. So you could form a group or choose to participate as a group, and by combining all of the group members' information, you could overcome that low volume threshold. As already mentioned, that performance is measured by a combined score for all of the folks in that group across all 4 of the performance categories. And in year 2, so this isn't an option for year 1, but clinicians with 10 or fewer clinicians can join something called the virtual group. So that would be that would not be tied to a single tax identification number. You could look across perhaps geography or specialty, and form a virtual group with some other providers. There's not a lot of details available on what these virtual groups will look like, and I know from speaking with CMS that they have a lot of work to do to kind of define what the virtual groups will look like and how they will form and the reporting and all that stuff. So there's still a lot more to come on the virtual groups. So this was the way that we expected to see the weights go across the composite score. So throughout this program, you are building something called a composite performance score, or CPS. The performance is weighted across those 4 categories. In the proposed rule, this is what we expected the weights to fall out. That did not finalize this way. So here is, we are in a transition year for 2017, and they've made a very significant change to those weights. The change is that we really only have to work with 3 out of the 4 performance categories in this first year. They have re-weighted the cost or resource use category down to 0 and shifted that weight to quality. So in the proposed rule, quality was going to be worth 50% or 50 points. It is now bumped up to 60. So this is a one-time thing. I think we will see things probably revert back to this in future years. We will see the cost category used in future years, but in this first year it is not. The reason for that is they added some new measures that go towards calculating that resource use or that cost, and they don't have a lot of good data on that yet. CMS is taking a year to collect more data on this particular, on the measures that go into figuring your resource use. So they're going to pause, gather more information, and then use this next year instead. As part of that transition year, we have something called Pick Your Pace as well. So we have some great options that will really can potentially reduce a lot of the reporting burden for you in this first year. But you need to be very cognizant about which of these options you are going to pick this year. Hopefully nobody picks the first one, which is don't participate. If you do not send any data, if you choose to bow out and not participate at all in this MIPS program, if you are a Medicare provider, you are guaranteed a negative 4% payment reduction 2 years from now. So when we hit the payment year in 2 years, if you don't do anything, you are guaranteed a negative 4% reduction. From there, the next option is to submit something. So you can test the program. This is submitting a minimum amount of information. For example, one single quality measure, so one numerator and one denominator on one quality measure, or one clinical practice improvement activity, or the base measures for ACI, and I'll talk about what all of these are in just a moment. If you do that minimum amount of information, you will negate the payment penalty. You won't necessarily get any kind of bonus, but your reimbursement level will remain the same 2 years from now. So it is really, honestly, very, very simple to avoid any kind of payment penalty, because you already have this quality data. It's easy enough to generate it out of your EHR. You just have to submit that data, and you're going to wipe out that payment penalty. From there, then, we've got 2 other options. We can submit for a partial year. So you submit for a 90-day reporting period across all 4 of the, or really 3 of those, the performance categories. And you can maximize your reimbursement potential. You can do the same for submitting for a full year. So there isn't a lot of difference between submitting for a partial year or submitting for a full year. It's just increasing your reporting period, going from anywhere from 90 days up to a full year. The reason you would want to do that is to get better scores. I talked about that throughout this program. You are building that composite performance score, and perhaps at the 90-day mark, you didn't do so well on the ACI measures. You know you can do better on quality. Report longer. Just extend your reporting period to give the providers more time to do better on the measures, and they can, again, maximize that potential. So that total financial impact is going to depend on how much data you submit and those performance results. But you can maximize the reimbursement levels with that submitting for a partial year as well. So this is pulled right out of the final rule. This is a guess on where CMS expects the numbers to fall based on participation. Again, this is just an estimate. We won't know exactly where things fall until folks report, and we kind of see where things are at. And again, it's due to that pick your pace options. There's a lot of variation there, so we don't know at this time how it's going to fall out. This is a guess. So CMS has set the performance threshold at 3 points. So on a 100-point scale for that composite performance score, if you get a 3 points, which to me is extraordinarily failing, that's going to wipe out that payment penalty. That you've gotten enough points to keep your reimbursement level at 0. So anything above the 3 points gets you up that slope and could potentially get you a positive reimbursement adjustment 2 years from now. So I talked about that submit something option where you could submit a single quality measure and negate your payment penalty. The lowest number of points you can get for any quality measure is 3. So no matter how dreadful your quality measure is, if you report it anyway, report that numerator and denominator, you're going to get at least 3 points for it, and it's going to at least wipe out that payment penalty. So then as you get a better and better score, you're going to maximize that reimbursement level. CMS expects things to sort of top out at the 70-point mark. So once you hit 70 MIPS points or in your composite score, you're going to maximize that base incentive. It was supposed to be a 4% increase, but because of this transition year, because of the pick your pace options that they built into it to give everyone a little bit of a break and transition into it, we know that's really going to cap somewhere around 0.9% instead. So still significant. If you're a Medicare provider, a 0.9% increase is still quite a bit extra in your bottom line. But it's not necessarily that 4% growth that we might have seen. There's also something called the exceptional performance factor. So folks that kind of go above that 70-point mark could split up some additional funds, and you could see that incentive go up to approximately 2.4%. So the name of the game is get as close to 100 as possible. So you can avoid that penalty by reporting at least 1 quality measure, 1 clinical practice improvement activity, or the 5 ACI base measures, which I'll talk about in a few slides. But that minimum 90-day performance can still get you the max incentive. So it all depends on what your composite score is in the end. As long as you're doing that 90-day period, if you're getting 100 on your composite performance score, you are certainly going to maximize your reimbursement potential. So that composite performance score, again, is it's weighted across these 4 categories. I'm going to go individually into each one of these 4 categories now. But first, we'll talk about, from a high level, about that composite performance score. The weights can be adjusted if there's not sufficient measures and activities that are applicable for each participant. So this is something very new and honestly a great change to the program. It is no longer a one-size-fits-all program. The program can adjust and kind of bend around the participant. The reweighting is automatic for some provider types, and I'll talk about that as we get a little deeper into the slide deck. And then there's an application process for others. That application process is not defined yet. There is no application, but it is coming. That performance threshold is established based on the mean or median of that composite performance score during the prior period. In years 1 and 2, because there is not any data to go on to calculate that mean or median, the Health and Human Services Secretary is going to establish that threshold for us. And we know for year 1, it is a whopping 3 points. That will not be 3 points in year 2, but we'll have to wait and see where they set that threshold in year 2. And then in year 3, that threshold is going to be the median or the mean of where everybody else fell in those first 2 years. So as we get deeper into this program, you're really competing against everybody else to maximize that reimbursement potential. You don't want to be in the middle of the pack because that's not going to do anything for you. You have to continually do better than your peers in order to continue to maximize your reimbursement level. Those who score below the threshold are going to see a negative payment adjustment, and those who are above it will see the positive adjustments. And any providers that are in the bottom quartile, so if you're in the bottom 25% of performers, you will automatically be reduced to the maximum penalty that's set for that year, and in year one it is 4%. So really the folks we will see getting that 4% reduction are the folks that chose not to do anything. If you submit any data at all, as long as you're successful in submitting that data, it's going to negate that for you. That penalty will go as high as 9% in future years. Okay, so we'll get into each of the performance categories, starting with quality first. So in summary, it is 60% of that final score in 2017. We'll see where it falls in future years, but in the first one, it's worth the majority of your score at 60%. There's over 270 measures that are available. You can see what they are now. You can go on the QPP website and get a list of what those measures are. In previous programs, like PQRS and Meaningful Use, you were reporting on 9 measures. In this new program, it is reduced to 6, so we have a little less than the reporting burden. One of those measures has to be an outcome measure or a high priority measure. Again, you can find out what those are on the QPP website. They're on a spreadsheet. We'll list them all as outcome measures, and there's a cool little tool on there where you can plug in the measure and it'll tell you whether it's a high priority measure as well. You can select from individual measures, or CMS has tried to make it a little easier for the specialties. It can be difficult for specialties to mine those 270 measures to find the ones that are applicable to them. So there are some specialty measure sets that have been set up to help you select the 6 measures that are most applicable to your scope of practice. There are several data submission options. So there's a lot of different ways to get the data to CMS. You need to be aware that the data submission option might change the reporting requirements. You have to be very careful to ensure that you are reporting properly based on the submission method that you choose. I have on here that these topped-out measures, they're not being scored any different in 2017. I just call that out because a lot of folks picked up on the fact that in the proposed rule, topped-out measures were going to be capped at 8 points instead of 10. That did not finalize. So whether it is at least for 2017, the topped-out measures, you could still get the full 10 points per measure. So here is a little screenshot of a very large spreadsheet that you can download from the QPP website that shows you some information, the benchmarks, and you'll need this for the scoring on your quality measures. So if you look at lines 4, 5, and 6, it's the same quality measure, but the submission method is different. So there's a different line for each submission method. This one can be reported by claims, direct from your EHR, or through a registry or a QCDR. This one does have a benchmark on it. I want to call your attention to that. You need to be very careful in this, at least in this first year. If you pick a non-benchmarked measure, meaning CMS is a relatively new measure, CMS has not collected enough data on it yet to establish benchmarks. The scoring on that could pose a problem in this first year. If it doesn't already have a benchmark, CMS is going to try and develop a benchmark for it based on submissions for this program year. But if they do not get enough providers reporting on that to create the benchmark, you are going to be capped at 3 points. The most you can get for that non-benchmarked measure is 3 points. So you could hurt yourself and hurt your overall score by picking non-benchmarked measures. And you'll see the scoring changes then depending on the submission method. So you can convert your quality scores to find out where they fall in these deciles depending on that submission method. You can find out how many points you get. So if you're doing claims-based reporting and you're at let's say 20.5, you're going to fall. You're going to you'd be in decile 4 for that, so you'd get the 4 points for that. You can see the topped-out measures in that final column. That's not really going to affect you too much potentially in this first year, but will probably be a factor down the road. But just be aware, if you look at those topped-out measures, you can see some of them you can't, a lot of the deciles are blank. So be careful in those topped-out measures. It's topped out because the vast majority of providers are scoring really, really, really high on that measure. So there's not a lot of variation between the lowest performers and the highest performers. So you could look at your quality scores and see that you're scoring at a 99.99%, and you'd think, gosh, obviously I want to pick that as one of my quality scores. I'm doing really well on that one. But if it is measure ID 100, look at line 8 there. Near perfection gets you a whopping 4 points. There are no points between 5 and 9, and so it jumps from near perfection at 4 points all the way to 10 points to get 100%. So you could really hurt yourself with those topped-out measures, so be careful. Picking your quality scores, I think, is one of the most important activities in this first year. Here's some example scoring on how the quality shakes out. You can get up to 60 points in your performance score. Again, you're just converting those scores. You take your numerator and denominator, convert it into find out where they fall in that decile, and convert it into points. You get at least 3 points, no matter which measure you pick. There are some ways to get some bonus points. You can get up to an additional 10% if you choose one. I talked about the different ways to get the data to CMS. If you choose one of the methods that is end-to-end electronic reporting, meaning you're not just keying in those values at a CMS website, the data is going directly from your EHR to CMS, you can get some bonus points there. If you're picking some additional high-priority measures, you can get some bonus points. And if you complete the CAP survey for MIPS, you can also get some bonus points there. You add those two together, you can earn as much as 70 points to receive the full 60 points. So earn anywhere from 60 to 70 points, and you're going to get the full 60 points for this performance category. Again, remember, you were trying to get as close to 100 points in that composite score as possible. Cost is the next one. I'm not going to spend too much time on this, mostly for a few different reasons. One, it's claims-based reporting. So CMS is going to be calculating this based on all of the claims that you are submitting. There's no additional reporting requirements for clinicians. But because this one is weighted at 0, it's not really a factor for us. So I'm not going to spend a lot of time on it right now. There are some additional episode-specific measures that have been added to address specialty concerns. And it's some of those new measures that have caused CMS to pause and not weight this category in the first year. We'll move on to the clinical practice improvement activities. So there are 94 activities available to you across 8 different categories, and I'll talk about what those are on the next slide. They are based on the patient-centered medical home standard. So if you are a PCMH office, these are going to be very, very familiar to you. I suspect they'll be familiar to just about anybody, too. The activities are categorized as high or medium weight. They're going to earn you either 20 or 10 points, respectively. You are shooting for, most folks are going to be shooting for 40 points to maximize the full 15% or 15 points that you can get in this category in this year. You have to have that activity implemented for at least 90 days. You do automatically receive full credit for being any kind of medical home. So if you're a PCMH office, you're already getting the full credit for that. Some folks probably just thought, well, hey, in the pick your pace option, does that mean I'm already set? Because I'm a PCMH office, does that mean I've already negated, as long as I report on that, if I negated my payment penalty? The answer is yes, because you're already getting that full credit. You're already at least going to negate that payment penalty 2 years from now. Then you get a minimum of half credit for any type of APM participation. So if you're in any kind of ACO, you can guarantee that you're going to get at least half credit. And then you can select some additional activities for full credit. I'll circle back on this because there's some, that's a very broad statement to get that half credit. I suspect a lot of folks, a lot of APMs will actually qualify for that full credit, but I'll talk about that again on a future slide. because most APMs or a lot of the ACOs are going to be categorized as MIPS APMs this year. So here are the 8 categories. There's actually 9 because participating in any kind of APM is going to buy you some points or some credit in this model as well. And I advise you to go to the QPP website. The list of quality activities is listed there. I suspect when you look at the 94 activities, you'll note probably half a dozen of them that you're already doing. If you care about good patient care, I guarantee there's a lot of them that you already have in place, and you've probably had in place for years even. You just have to attest to those. Those ones are fine. You can still use those. You can attest to having those in place for at least 90 days in 2017, and you can get credit for them. So you don't have to reinvent the wheel here. The scoring considerations, there's a few different ways to score here. Most folks will be shooting for 40 points. If you are a small practice, meaning you have a practice of 15 or fewer clinicians, you are a small practice, and you're only shooting for 20 points. Also, practices located in rural health areas or geographic health professional shortage areas, or if you're a non-patient-facing clinician, you'd also only need 20 points to get to maximize the 15%. All right, the 4th category is then Advancing Care Information, or ACI. This is a program formerly known as Meaningful Use. The scoring here is based on some key measures of health IT interoperability, promoting patient engagement and electronic information exchange. So it pulls forward a lot of the same measures you've already been working on for years under Meaningful Use, but has a heavy focus on interoperability and patient engagement. It has dropped the all or nothing thresholds for measurement as well as exclusions. So if you're used to claiming exclusions on these measures, there are no exclusions. But there are also no thresholds that have to be met. So whatever your numerator and denominator is, it's going to translate into scores. It has dropped the CPOE and CDS objectives that you've been working with under Meaningful Use for years. Those measures are still part of the Medicaid Meaningful Use program. So don't go in and shut off your CDS rules. It's just bad for patient care, but if you're a Medicaid Meaningful Use provider, you still need CPOE and CDS to be on your radar. It reduced the number of required public health registries that are reported. So MICR, the Michigan Care Improvement Registry, the immunization registry, is really the only one that you really have to pay attention to in this program to get performance score points. Anything beyond that, if you connect to the cancer registry or MITRE or any other great registries available to you here in the state, you can get some bonus points there. You also can get some up to 10% bonus points for linking your health IT or your EHR to your clinical practice improvement activities. So CMS has tried to link those to your health IT to your CPIA to give you some bonus points. So for instance, the best example is one of the 94 clinical practice improvement activities is increasing access to your practice, providing 24/7 access. If you are doing that via your patient portal, then you can get some bonus points there because you are linking your technology to those activities. There are 2 scores that are calculated as part of the ACI category. You get your base score and your performance score. So the base score is worth 50 points, and I'll talk about each one of these in just a moment too. But the base score is really the only place where we have an all or nothing. You have to do everything that's contained in the base score measures to get those 50 points. From there, you get your performance score. From there, the program circles back and really looks at those numerators and denominators for the different measures. As I mentioned, there are no more thresholds. There are no exclusions. So whatever your numerator and denominator is, it will convert into points that go into making up your performance score. You can get upwards of 90 points out of it. I talked about the different bonus points that you can get for connecting beyond MICR and linking your technology to your clinical practice improvement activities. You can get an additional 15 points, and that all goes towards building your composite score. If you do some quick math here, you see that there are 155 points available. But as soon as you hit 100 points, you have maximized the points that can go into your composite score. So it is worth 25 points or 25% in this first year. You earn 100 points here, and you've got those 25 points. Get anywhere above that, it doesn't give you additional points. You've already maximized and gotten those full 25 points. So a little more detail on each one of those different types of scores. We've got the base score, makes up those 50 points. This is, again, the only place where it's all or nothing. And there are two different lists of objectives in the ACI structure for this year. We have the transition objectives for 2017, and then what we'll call the regular objectives from this year forward. The difference here depends on what technology you have. What version of your EHR are you on? If you are on 2014 certified technology, which will be 99.99% of you out there, you are going to be working in the transition objectives, this first column. In 2018, the next version of your EHR is mandatory. You will have to be on your 2015 certified technology by the start of next year. If you didn't already know that, your vendor is undergoing another upgrade and working on certification right now to try and get 2015 certified. Once they have that and they get you upgraded, you would then be able to participate in the regular measures. But for this first year, if you are still on your 2014 technology, which again was probably just about everybody, you're in that first column. So there are 4 measures that then make up your base score, and you have to achieve each one of these to get the base score. However, it is one of everything. So looking at the ERX measure, if you send 1 electronic prescription, you've met the objectives for the base score. If you electronically send 1 summary of care document to that next provider of care electronically, you have met the requirements for that base score. Do your security risk analysis, you've met the requirements, and provide patient access. Get 1 person signed up. Get 1 person signed up for the patient portal, and you have met the objectives for that base score. So it's one of everything gets you those 50 points. The only difference in the other set of objectives is the health information exchange. When we get into what is essentially stage 3 measures, that the HIE measure splits off into a couple of different measures. So then we get the performance score, which you can get up to 90 points. And again, there are no thresholds. No matter what your numerator and denominator is on these measures, it converts into points. So you've got the list of measures here. Again, we've got the transition objectives for this year for anyone who is still on 2014 technology. Even if you get upgraded mid-year, if your vendor gets certified and let's say they get you upgraded in August, because you started the year, because you were on 2014 technology for part of this year, you'd have your choice. So you could move ahead once you get on to 2015 technology and move on to the regular set of measures, but you've got the option to stay on the transition objectives for this year. So again, yeah, we've got 2 different sets. The health information exchange splits off into 2 measures. Under the transition objectives, it's worth 20 points, so you would just double your points for that one. Same thing with provide patient access is worth 20 points under the transition objectives. When we get into the regular set, it is 10 points for providing patient access, and then 10 points for the patient-generated health data. So how do you calculate that score? Again, you just take your numerator and denominator, convert that into that performance rate, and then find how many points you get for that. So look at that example at the bottom. If you have a clinician who submits a numerator and denominator of 85 out of 100 for the patient-specific education measure, their performance rate is 85%. Look on this grid to see where 85 falls. It's in the 9th decile, so they would earn 9 points for that measure. Again, for those 2 measures that are worth 20%, you're just going to double that percentage here. So if that was this one, if they were at the 85th percentile on this one, they would have just gotten 18 points instead of the 9. Kind of wrapping it all together, you get that base score earning as much as 50 points. So you can't get you can't get 49 points there. You're either going to get 0 points or the 50 points for getting the base score. That's the only place where we still have an all or nothing component. You get your performance score by just converting your deciles into points. You get your bonus points of up to 15, and you earn that composite score. So again, a good example at the bottom, you get that the clinician has achieved the base score, so they did one of everything to get that done. They got a 40% for the performance score and no bonus points. They would earn a 90% in the advancing care information performance category. Then because it's weighted at 25%, we have to figure out what is 90% of 25. So it equates to 22.5 points to their overall MIPS final score. I talked about how the ACI score can be reweighted for a couple of different ways. This is the first way here. This is not the way I think most folks will see their score reweighted, but it is possible to get reweighted if you have insufficient internet connectivity, extreme and uncontrollable circumstances, or lack of control over the availability of cert. I will pause here. If you are an employed physician, you don't automatically qualify for that lack of control. Even if you're not an owner, you're just an employee, CMS still assumes that because you work for the organization that you have some level of control or some influence over the availability of cert. So just because you're not a practice owner doesn't mean you qualify for that. So these ECs must submit an application to have that reweighted, to have the weight shifted elsewhere, and it would get shifted to quality. But that application process is not yet available. So the other way that you can get ACI shifted or reweighted is by if you are one of these provider types. So if you are a hospital-based clinician, if you are a PA or an NP or a clinical nurse specialist or a CRNA, or if you lack face-to-face interactions with patients, you would qualify for an automatic reweighting. So CMS already knows if you are one of these provider types, and they will automatically reweight your the ACI performance category down to 0 for you, and it would shift over to quality. This kind of summarizes things a little bit on a lot of everything else I've talked about up to this point. The box at the top gives you those pick your pace options. So in each of the 3 remaining categories for this year, if you're just looking to negate that payment penalty, you're going to report something. It has that listed, what you'd have to do. Again, it is the base score for ACI or one single quality measure or one CPIA measure. That's going to negate that payment penalty. If you go anywhere from a 90-day reporting period to a full year reporting period and hit all 3 of these categories, you could maximize your score, maximizing that reimbursement potential. And then the grid at the bottom here kind of shows you, kind of depending on the number of points you do get, again, it is through up to 100 points available, you can see where you'd fall. As soon as you get to 3 points, it's going to negate that payment penalty. Anything above that can give you a positive adjustment. It's going to sort of top out around the 70-point mark. And if you get above that, you're going to get into the exceptional performers bin then. I also talked about a little bit how there are many different ways to get the data to CMS. This is in each of the 3 categories. Again, if you recall that cost, not only is it not going to be used this year, but that is all based off of claims. You're not submitting any additional data. But for the other 3 performance categories, you have to submit some data. Be very careful, as I talked about in quality, depending on the method that you choose, that's going to shift the reporting requirements. And as you saw on that previous slide, it also shifts the benchmarks. So what could look like a fantastic score might score really well through, let's say, registry reporting, but through claims-based isn't so good. Group registration. So if you are going to pick the web interface option, or if you're intending to complete the CAHPS survey for MIPS, you do still have to register as a group. So similar to the GPRO option under PQRS. It's the same portal, the QualityNet portal that you've done in the past. You do have to register if you are intending to submit via GPro this year. So just like in previous years, they had a June 30th cutoff to register for that submission option. That is still in place for this year for that option in MIPS as well. I'm not going to spend too much time on here, but if you're just not really sure what I was talking about with all those different submission methods, here's some definitions about each of those. You can circle back, grab the slide deck and circle back and read all those if you need some help. There are some checks and balances that are being built in as well, which is great. Some performance feedback will be available at least annually. I suspect we might get stuff a couple times a year, or that's what I'm hearing. So in July of this year, you will get some minimal data that will address the quality and cost performance categories. So CMS will kind of give you a clue on how you're doing. I think we'll see this again potentially in December. And then there's an opportunity to request a targeted review of the calculation if you think there is some sort of error embedded there too, if CMS has made an error. So what's it all mean? Once you go through all those performance, you generate your composite performance score, what does it mean in terms of payment adjustments? So as we have seen in PQRS and meaningful use, there's always a 2-year lag between the performance year and the payment year. So we are in our first performance year in 2017. It is going to affect your payments in 2019. This program is budget neutral. So the clinicians who are receiving negative adjustments are going to be paying for those that are receiving positive adjustments. And that is why we get into what was supposed to be a 4%, up to a 4% increase in this first year. And now we're seeing it's probably around a 0.9% increase. It's because of that budget neutrality. Because of those pick-your-pace options, we know that there are going to be very few clinicians that are going to get penalized in this year because it's just so easy to avoid that. So because there's not too many people getting penalized, there's not enough money to incentivize the others. So that's where the budget neutrality comes in, especially in this first year. It's a linear adjustment based on that composite score. Again, this is different than we've seen in previous programs in meaningful use in PQRS. The payment penalty was the payment penalty. And if you got penalized, that was a set percentage. That is no longer the case. You can be anywhere between the low end and the high end. So you could be anywhere between negative 4% and what was supposed to be plus 4%, but we know it's going to be more like 0.9%. I already mentioned those scoring in the bottom 25% will be automatically adjusted down to that maximum penalty for that program year, which we know in the first year is 4%. Higher scores receive proportionally larger incentive payments, up to 3 times the maximum positive adjustment. We're not going to see that come into effect in this first year, again, because the pool of money is going to be so much smaller than we will see in other years. But in order to maintain that budget neutrality, there's a 3 times modifier built in to kind of spread out those payments. So to ensure that the money that's being captured by those receiving the penalties is being distributed to the top performers. There's also the highest performers are also eligible for an exceptional performance bonus. I talked about the budget neutrality. This steps away from that. There is an additional $500 million a year that is being set aside for the highest performers. So anyone that's in that top 25% could be splitting up as much as an additional 10%. So there's the potential for a tremendous increase as we get deeper into this program. When you look at that maximum reimbursement potential of 9% times the 3 times modifier plus the additional 10%, we could see you could get a 37% increase on your Medicare Part B reimbursements come 2024. Could be pretty awesome, I would assume. Here's a little diagram that kind of summarizes a lot of what I've talked about already about the incentive payments. We've got that performance threshold in the middle, which we know in the first year is at 3. That will not be 3 next year. Anyone above that is in the green. Anyone below that is in the red, with those in the bottom 25% getting reduced to that maximum reduction of 4% in the first year, goes as high as 9% a few years from now. And once you get into that, the exceptional performers bucket, and that's anyone in the top 25%, that's when you get the additional $500 million a year that you'd be available to split up as well. So how do you prepare and to participate in MIPS? So here's some kind of high-level suggestions, a little checklist here for you as you try to make sense of this and kind of get your feet underneath you in the MIPS program. You're going to determine your eligibility and understand those requirements. You need to choose whether you want to submit data as an individual or a group. You're going to choose your submission method and verify its capabilities. Just because you would like to submit data a certain way doesn't mean your EHR vendor is capable of doing that. So you want to work with your vendor, make sure that you can submit the way you'd like to. You need to do all that before your reporting period would be nice. You're going to prepare to participate by reviewing the practice readiness, your ability to report, and then those pick your pace options as well. Choosing your measures, I think, is one of the most important activities. Because it is the biggest weight, that is 60% of that composite score, and because there's so much variation here between the benchmarks and your submission methods and what that does for the reporting requirements, I think the most time probably should be spent here really carefully choosing your measures. Go to the QPP website. There's some great resources and tools there for you. You can look at your QRUR report if you were previously a PQRS participant. That can give you a good idea. You could go to the spreadsheet that's available on the QPP website. I showed you a screenshot of it earlier, and convert last year's QRUR report into deciles and find out if your provider did exactly the same in this performance year, what would that quality score look like? You're going to verify the information that you need to report successfully. You're going to care for those patients and record the data in designated fields. That means using structured data fields. If you are just free texting everything into a progress note, you're not going to score on quality. You have to ensure that your providers are recording the data where it is supposed to go. If you're not doing that, you've got some work to do in terms of workflow. You need to get your providers recording the data in structured data fields. Otherwise, it's not going to translate the way you need it to. And then we know the submission deadline for this performance year will be, I think, at the end of March of 2018. So you'll be attesting between January 1st of 2018 and the end of March of next year. Okay, that was one of the two paths. The other path in participating in this model is then the alternative payment models, or APMs, or more specifically, advanced APMs. So what are APMs? So they are, it's a generic term that describes a payment model in which providers take responsibility for cost and quality performance and then receive payments that are adjusted on that cost and quality. So according to MACRA, APMs in general include the Medicare Shared Savings Programs, so tracks 1, 2, and 3 of those ACOs would all be APMs, demonstrations under the Healthcare Quality Demonstration Program, CMS Innovation Center models, and demonstrations required by federal law. So when you see APM, for the most part, you can think ACO, at least in the current options. That's going to change as we get a little bit deeper, and I'll talk about that in a future slide. But the thing to point out here is that MACRA does not change the way, does not change how your ACO is paying for medical care. It's going to build on top of that. So whatever your agreement is with the ACO, that stays in place under this program. You just get incentivized on top of that for meeting the program requirements. And then APM participants may receive some favorable scoring under certain MIPS performance categories. As I talked about, if you are in any type of advanced payment model, you're going to at least get half credit under the CPIA category. Some APMs then are considered advanced APMs, and that's really what we're shooting for here. That's the gold standard. There are different types of APMs. The vast majority of APMs out there are what's considered MIPS APMs, where you receive some favorable MIPS scoring in this program, but they don't qualify enough. There's not enough there to kind of get you out of that MIPS track. So it's called the MIPS APM because it gets you some scoring, it gives you some benefits in the program, but doesn't get you away from participating in MIPS. From there, we get into qualified medical homes. Those would be, those are advanced APMs. We don't have any of those today, but they have a risk structure that is built in, and they would be treated as advanced APMs. And then we have that at the top of the pyramid here, the advanced APMs. These have the greatest risk and offer the potential for the greatest rewards as well. Again, that is the end goal. If you think back to that staircase that I showed you of the different categories, and then that next one that showed you the different bubbles, that top of this pyramid here is the top of that staircase. That's where we're trying to get everybody. There's certain criteria to become an advanced APM for your ACO. To hit advanced APM status, it needs to have some things in place, one of which is 50% of the participants must be using certified EHR technology. They must report on at least partially based clinician payments on quality measures that are comparable to MIPS, so those 270 plus measures, they have to be using those same measures or ones like it. This is where we kind of, for the most part, draw that line in the sand. There has to, the APM entity has to bear more than nominal risk for monetary losses. So there has to be enough risk built into the model, and if there is not enough risk built into the model, it's going to be a regular APM or a MIPS APM. It's not going to reach advanced APM status. So that's sort of the dividing line between a non-advanced APM and an advanced APM is looking at the amount of risk that's built in. So incentives for being in an advanced APM participant, as I talked about in that model design, your APM already has shared savings built into it. So whatever that payment methodology is, you've got those flexible payment bundles and whatever other desirable features are built into that model that you're already working under with your ACO, that stays in place. So you've still got those incentives. This program then builds on top of that. You could, for the next 5 years, get as much as an additional 5% lump sum bonus off of your own individual Medicare Part B charges. But that is only for certain folks that are participating in advanced APMs, and I'll talk about that on the next slide. You get higher reimbursement updates. So if you are in an advanced APM, a few years down the road, we will start to see the physician payment schedule shift a little bit. It's going to lock in place for about 4 or 5 years here coming up. And the only way to get it to move is to participate in this program. In 2026, it will unfreeze and start to move again. So if you are in an advanced APM, it will go up 0.75% each year. For everyone else, it will only go up 0.25%. And if you're in an advanced APM, you don't have to participate in MIPS at all. So, but there's one qualifier there, and that is that you have to be a QP, a qualified APM participant. So it's not enough to be part of an advanced APM. Your advanced APM then has to become a qualifying APM. A qualifying APM is one that meets increasing thresholds for the percentage of charges that pass through the APM's methodology. So it's set at, I think, 25% for the first year. We will see that increase, but the only way to become a QP, or a qualified APM participant, is to ensure that, that globally, across all APM participants, at least 25% of payments are being passed through your ACO's payment methodology. That QP status is awarded to all of the APM participants collectively or to none. So it is not an individual status. Either all of the ACO members are going to be QPs or none of them are. And that's really where you want to be. You need to, if you're in an advanced APM, you need to be a QP in that advanced APM. That's where you get that 5% lump sum bonus. So what if you're in an advanced APM, but that QP status is not met? So you'll find yourself with some options in that bucket. So if the advanced APM does not meet that volume threshold to qualify its members for QP status, members are considered partially qualifying APM participants, or PQPs. So if you'd like to, if you find yourself in that bucket, you could choose to stay in the APM track, meaning you're not going to participate in MIPS. You're good with the shared savings that is built into that ACO model. It's a big bummer that they didn't hit QP status, but you don't really want to do anything more. You're not going to receive that 5% lump sum bonus, but you're not also subject to the MIPS payment penalties. You do have the option, though, if you find yourself in that as a PQP, individually you would have that option to participate in the MIPS track. So you're in an advanced APM, but your APM did not get enough payments passed through that ACO's payment methodology, so you did not get QP status. You find yourself being a PQP. You could opt into the MIPS track. So you're gonna submit on those 3 different performance categories I talked about: ACI, CPIA, and quality. You're going to get a composite score, and that composite score could adjust your payment reimbursement a couple years from now. So if you find yourself a PQP, you've got a choice to participate in MIPS or not. There are not a lot of advanced APM options right now. We will see this change year after year. We'll see this list grow. Right now, as of this year, these are the only advanced APM options: the comprehensive ESRD care model. CPC Plus qualifies as an advanced APM as long as you are in a group of less than 50 providers. In the CPC Plus model, if you are participating, if you're in a group that has more than 50 providers, the amount of risk gets below the mark to be qualified as an advanced APM. So be careful there. A lot of folks are assuming they are in an advanced APM because they are in CPC Plus. But if you find yourself, if you're participating in CPC Plus in a large group, you might knock yourself out of advanced APM status. Medicare shared savings tracks 2 and 3 qualify. The vast majority of ACO participants are in track 1. That is a regular APM or a MIPS APM that is not an advanced APM. But if you're in tracks 2 or 3, that qualifies. The next generation ACO model also qualifies in advanced APM, and there's the track 2 of the oncology care model qualifies as an advanced APM. We've got some new options coming as of next year. There is something called ACO Track 1 Plus that's coming. That will qualify as an advanced APM. They're also, I know they're reopening the CPC Plus. So if you didn't get in on the first round of applicants, there will be an opportunity to join the CPC Plus. And we've got some other options that are coming too. And this list, again, will grow considerably. The CMS has said they will update this list on an ad hoc basis. So you can access this list of advanced APMs on the QPP website. And go back to it every month if you'd like to. And hopefully we'll see this list grow. So the qualified medical home models, if we think back to that pyramid of advanced APMs, this was in the middle of it. So a medical home model could qualify as an advanced APM. As of today, we don't have any of these. So the only way for a medical home model to achieve advanced APM status is to expand under CMS authority. And again, getting back to that risk, there has to be enough downside risk built into that payment methodology in order to become an advanced APM. I'm not going to spend a lot of time on this because there are no qualified medical home models as of today. I think we will see that expand as some of the medical home models that are out there work with CMS to expand and build enough risk into that model. We will hopefully see some of them qualify as advanced APMs in the future. So really just about any medical home right now is going to qualify as a MIPS certified medical home. So this was a nice change that we saw, a nice change between the proposed rule and the final rule. In the proposed rule, only national programs were going to qualify. Regional or state programs or private payer programs were not going to qualify. Thankfully, they changed that when they finalized this rule, and now really any certified medical home model is going to qualify as a MIPS certified medical home. So that means in the state of Michigan here, of course, we've got 1,500 or so practices that have been certified under the Blue Cross model. those would all qualify here. And then advantages to being a certified medical home is you receive full credit under the CPIA activity. I touched on that already. So if you are in a medical home, you already have the full 15% credit for your CPIA activities. Even better, if you are practicing in a larger group and even one of your practices under that same TIN is a certified medical home, then all the clinicians that are reporting under that same tax identification number already have full credit under the CPIA category. Really good benefit there. So then we have kind of the bottom of the pyramid there, the MIPS APMs, the non-advanced APMs. This is the vast majority of ACOs that are out there qualify as MIPS APMs. I think almost 90% of the ACOs, the MSSP ACOs are Track 1 ACOs. They would all qualify here as MIPS APMs or non-advanced. The criteria here is the APM entity participates in a model under an agreement with CMS. Includes at least one MIPS eligible clinician on a participant list, and then the payment incentives are based on cost and quality measures. Again, I already mentioned the vast majority of Medicare ACOs are Track 1. Those would qualify in 2017. So the advanced APM benefits don't apply. So you don't get that 5% lump sum bonus. You have to participate in MIPS to receive any favorable payment adjustments. And you're not eligible for that higher baseline annual update beginning in 2026. So you wouldn't qualify for the 0.75 increase. You'd qualify for the 0.25% increase. But some great benefits still for being in a MIPS APM. You get that full credit under the clinical practice improvement activities. You get that shared savings, whatever is already built into your ACO model. You get to share all the money there. And then you are eligible for annual MIPS bonuses, so which continue indefinitely. So the 5% lump sum bonus right now anyway is only in place for up to 6 years, whereas the MIPS track is in place indefinitely. So you could increase 9% as you get deeper into this program. This slide kind of summarizes a lot of what we've already talked about, what the conditions are for the patient revenue thresholds, if you have to participate in MIPS or not. So that first column, the qualified participant in advanced APMs, again, that is the gold standard. That's what we're shooting for here. That shows you what it means to be in that column. We have partially qualified participants, or QPs, in the middle, and then the vast majority of APM participants are going to be in that final column, where the patient volume thresholds don't apply because there is no lump sum bonus that applies. You don't have to achieve QP status if you're a MIPS APM participant. You do have to participate in MIPS, and then you can get that favorable weighting and for being part of an APM, and that scoring can then increase your reimbursement a couple years from now. So trying to conceptualize the main question here in the middle, how does the QPP affect me? So start in the middle, am I in an APM? If the answer is yes, I'm in some sort of APM, you then have to figure out if you're in an advanced APM. Are you one of the few APMs that qualify this year to be an advanced APM? If the answer is no to that, you still get some favorable MIPS scoring for being part of an APM, but you do need to participate in MIPS to receive additional rewards. If the answer is yes, you have another qualifier there. You have to figure out if your ACO has had enough payments or patients pass through its payment methodology. Again, if the answer is no, you find yourself in the middle. You still get some good favorable scoring in the MIPS categories, and you get those shared savings, but you still have to participate in MIPS. If the answer is yes, you find yourself a QP, which is where everybody wants to be, where you are excluded from MIPS. You get that 5% lump sum bonus, you get the higher fee schedule updates, and you get your APM specific rewards, whatever those shared savings are. Go back up to the top to that original question, am I in an APM? If the answer is no, then you can look at that low volume threshold, or if you're a first-year Medicare provider, you qualify for that low volume threshold. The answer is no, meaning you've had over $30,000 in Medicare Part B allowable charges, and you've provided care for over 100 Medicare patients, then you're subject to MIPS. The answer is yes. You're under that threshold. You don't have to participate in MIPS. The bottom line there is that if you're in any type of APM, anything at all, whether it's an advanced APM or not, you are going to receive some incentives for being a part of that, even if you don't become a QP. So, some QPP odds and ends here as I start to wrap up. I talked about hospital-based status, where that is one way to get your the ACI reweighted to 0 and would shift to quality. Determining that has changed a little bit from previous programs. In the Meaningful Use program, a hospital-based clinician had 90% of charges billed to place of service 21 or 23. They've changed that a little bit. They've lowered their percent. Now it is 75% of charges, and they've added an additional place of service. So now that is 75% of charges billed to place of service 21, 22, or 23. That would make you a hospital-based clinician, and that would reweight your ACI category down to 0 and shift it to quality. So you'd only have the 2 performance categories to work in under MIPS, with quality being 85% and clinical practice improvement activities at 15. I talked about this. If you are on 2014 technology for part of the year and 2015 technology for part of the year, which I think will be hopefully the majority of you if your vendors get certified and can get you upgraded, you got a choice where you could still stick with those transitional measures, or you can, if you're on 2015 technology, you can choose to move ahead into those regular ACI measures. They will be mandatory next year. There is some limited MIPS eligibility info on quality that is available now on the QPP website. This is if you are a PQRS participant submitting data electronically. You'll see some of that data showing up now for you already on the QPP website. Comparisons, I touched on this a little bit, but I just want to draw your attention to it again. I talked about in terms of quality. When you're picking your submission method, the benchmarks change as I showed you, depending on if it was claims-based or one of the electronic methods. Be very careful, because in this program you are being rated against everybody else. But in terms of submission methods, you are being rated against everyone else who chose that same submission method. So those benchmarks are changed. The benchmark changes. So if you're submitting quality through one of the electronic methods, you are not being compared to somebody who is submitting on doing claims-based. You are only being compared to folks that are chose the same submission data method that you did. And that's where the benchmarks come in. The benchmarks will change each year as well. Group versus individual data submission can be decided at the time of attestation, so you don't have to decide that now. You can opt into a group right at the last second. The only place where you do have to decide ahead of time is if you're using the web interface to submit your quality data. You do need to do that GPRO registration before June 30th of this year. Different reporting periods can be chosen for each performance category. So if you're only choosing a 90-day reporting period, you don't have to use the same 90-day period for all 3 performance categories. If you did really well under the ACI scoring in one 90 days, but you did better in another 90 days in terms of quality, you can call out different 90-day reporting periods to maximize your score. Medicare Advantage does not qualify right now, so if you're looking at the low volume threshold, ignore that Medicare Advantage. It also is not going to affect those payments if you're getting penalized or incentivized. That could change in year 3 because Medicare Advantage plans could be considered advanced APMs, again, if there's enough risk built into them. We could see a Medicare Advantage become an advanced APM. A few more odds and ends. Mid-level providers must participate in MIPS, but ACI is optional. I talked about that already. That is one of the provider types that will receive an automatic reweighting under, CMS already knows if you're an NP, so they're going to automatically reweight that. But it's your choice. You could opt to still report on ACI. So you don't have to, but if you do, CMS will take those scores and adjust your composite score accordingly. This is a big one, the second one. If the clinician works for multiple employers, each NPI and TIN combination is going to generate a separate MIPS score that will potentially affect reimbursement rates differently at each one of those employers. Furthermore, if a clinician is new to an employer in a payment year, his or her MIPS score from 2 years ago in that performance year is going to follow that clinician to the new employer. So I think this will become a question during the interview process when you're hiring new physicians. You're going to need to know, starting this year, how did they perform in MIPS in 2017? Because 2 years from now, if they worked somewhere in 2017, but they're working for you in 2019, whatever they did in 2017 is going to follow them. If they were working at multiple employers in 2017, the best one is the one that's going to follow. So if they got a great composite score in one employer and a not so good one in another employer, when they come to work for you in 2019, the best one is going to follow them forward. There are 3 snapshots that are going to be taken to determine both advanced APM status as well as QP status. The dates are the same, March 31st, June 30th, and the final one in August 31st. What that means is, on March 31st, CMS is going to look at the APM participant lists and figure out who is already on a participant list for one of the advanced APMs. That's going to lock you into advanced APM status. Same thing on QP. Once you're in an advanced APM, if your ACO meets QP status by March 31st, you've got QP status for the remainder of the year. You don't have to worry about losing it. They will do that again on June 30th and the final time on August 31st. So by August 31st, you have to make sure that your ACO is going to get all of its members to be a QP status. If you do not reach QP status by August 31st, you cannot be a QP, meaning you will not get that 5% lump sum bonus in your advanced APM. FQHCs and RHCs, regional health centers, are for the most part exempt. You can still opt into practice. I'm not really sure why anyone would want to, because it's not going to affect your adjustments. However, some facilities, some FQHCs that we work with, we know are billing some Medicare Part B, like for labs or radiology. If you are billing Medicare Part B, you could tip the scale on that low volume threshold. If you do, those providers will need to participate in MIPS to avoid any sort of reduction in those Part B reimbursements 2 years from now. So just because you're an FQHC provider, don't assume that you are exempt. You need to look and see if you are one of those that are still submitting some limited Medicare Part B, and then you need to look at that low volume threshold. If you tip the scale on that, then you are a MIPS provider, even though you're in FQHC. Critical access hospitals do have to participate. Other hospitals do not have to. CAUs do have to. But the details of participation is going to depend on whether you're practicing in Method 1 or Method 2 and whether or not the clinician has reassigned the billing rights to the CAU. We have a MACRA timeline here. So we just finished up. We're in the last, the attestation period for 2016 for PQRS and Medicare Meaningful Use. You're preparing for QPP participation. We're in that first performance year now for MIPS. The APM criteria has been set. 2018 is the first performance measurement year for the APMs. So what I'm talking about there is that what goes towards figuring your 5% lump sum bonus. If you are a QP in an advanced APM this year, in 2018 is what's going to go into figuring your 5% lump sum bonus. So you'll look at all of your Medicare Part B charges for 2018, and in 2019 you'd get a 5% lump sum bonus based on those 2018 charges. And then 2019 is that first MIPS payment year. So you can see a maximum of 4%, or really we know it's really more like 0.9%, but you could go as low as 4%. The first APM performance is assessed. You get that 5% lump sum bonus based off of those 2018 payments. Another look at the timeline. I'm in the interest of getting to any questions, which I see I don't have any, which blows my mind. I don't have any questions yet. We're coming up on questions, folks. So if you have any, please get them to me. We have the timeline here. We can see the fee schedule is still going to increase at 0.5% for the next few years. As of 2020, it's going to lock in place. And the only way to get it to increase your reimbursement level is to either participate in MIPS or to become a QP in an advanced APM. As of 2026, we can see that level move up a little bit. We've got the 4 performance categories in the middle for MIPS. We'll see that the first payment year, it can go up or down 4%. We'll see that increase. As of 2022, it's going to top out at 9% and can increase 9% from there on. And then we have the APM, the qualifying APM participants can receive that 5% lump sum bonus, and you're excluded from MIPS. Some concluding thoughts here as we wrap up. We are in the beginning stages of long overdue payment reform. So as we've seen with the Meaningful Use program, how it looks right now is not how it's going to look down the road. We know that CMS is going to have to continue to refine things. So we are in the very beginning stages of this. We're going to see it continue to evolve. Again, the long-term goal is to push everyone up that staircase. We want to get folks into the advanced APMs, and that's where you have the biggest potential for on the financial side. Those MIPS bonuses are potentially significant for high performers. You can get all the way up to a 37% bump in your reimbursement level. There's also significant risk at as much as a -9% penalty. So if you look at that, we could see, as we get deeper into this program a few years down the road, we could see a 46% gap between the highest performers and the lowest performers in terms of that Medicare reimbursement. I'm guessing that's going to make or break a medical practice. Don't forget about the current rules that are still in place. We are wrapping up again, we're in the attestation period right now for these legacy programs that are now being combined into that single program under MIPS, but we still have some attesting to do to finish that out. We've got some resources for you here. First and foremost, the QPP website, and some others there. Again, that website, everything else here is essentially on the QPP website. Really good website. I highly recommend you go to that site and kind of poke around, especially when you start to look into selecting your quality measures. There's some great resources there that you're going to need to pay close attention to. And with that, I will open up to questions. I know we're getting right to the end, and I didn't have that many. We've got 2 questions here. I'll go through these real quick, and then we'll have to wrap up for the day. Where can the points and / benchmark spreadsheet be found? It is in an odd place on the QPP website. It looks in the section when you go into resources down at the bottom. It's actually listed as though it is meant for vendors, and I don't know why it's listed there. Hopefully they make a shift there. But look under the categories of resources that it appears to be for vendors. You'll find the spreadsheet there that you can download. That I had a screenshot of it earlier on one of the slides. It shows you all the benchmarks and all the relative and all the data submission options and how that shifts your benchmarks and deciles. And how does one confirm he is in an ACO? Well, hopefully you would know if you've signed up for an ACO. That's something that's a contract you would have signed specifically yourself to join. So if you're not aware, if you're in an ACO, chances are you are not in one. But I would, look, if you have a business manager, I would talk to them and see if you've been signed up if you've applied for an ACO. With that, that is all the questions I have for today, as well as all the time I have for today. You have my website and my email address and phone number there on your screen right now. If you come up with anything, if you have any questions relative to the QPP, feel free to hit me up. If you'd like to talk about any of the technical assistance and contracting with us, please give me a call or shoot me an email. I would love to have that talk with you as well. I will most likely be redoing this presentation again next month. Each month we get additional clarification from CMS, and so every time my presentation changes a little bit, and I guarantee you repetition is the key here. I know a lot of folks on today's call have been with me several times through as many as 4 and 5 of these presentations, and I suggest you do the same. One pass through this material is not even close to enough to be able to assimilate it all. So please come back. You can go to the MCDA website. I don't have the next webinar scheduled yet, but I will be setting that sometime in the next few days. You can go to the MCDA website there and can register for the next webinar on MACRA, as well as any other ones that we offer. Thank you so much for participating today, and I look forward to seeing you again. Goodbye.